Hello. Before I start, I would like to greet the moderators, the other guest speakers, and the audience. Also thank the scientific committee for the kind invitation. It's a pleasure to be here. As you can see, the work that I'm going to present is about self-cannulation, a way to autonomy. This is the outline of my presentation. Needle placement is the most stressful part of a dialysis treatment because of the lack of control over the person cannulating and the pain associated with it. But this needle fear does not mean that the patient is weak or childish. It's a natural and intended response of the human body, and in some extreme cases, it can be a specific phobia called blood injection injury type, listed in the DSM manual, the official book of psychiatric disorders. On the other hand, patients who cannulate themselves learn to overcome their fears, improving self-care and preserving their own vascular access. It is well established that self-cannulation extends the life expectancy of the native AV fistula and is associated with fewer complications. This idea is reinforced by the KDOQI guidelines recommending that patients who are capable and whose access is suitably positioned should be encouraged to self-cannulate. Thus, the buttonhole technique is especially attractive for this technique and for self-cannulation, and has been recommended for most authors as the method of choice. So, based on the principle that autonomous patients experience less pain, as well as less associated complications on cannulation, the Nephrocare Coimbra nursing team developed a project with the main objective: promote self-cannulation in dialysis patients. How? Creating a teaching self-cannulation program. With respect to the methods used, first, we defined basic criteria for inclusion of the patients in the program, such as AV fistula, cognitive capacities, good hand dexterity, good eyesight, cannulation buttonhole technique, and, as the most important, willingness to join the program. Then, according to the scientific research conducted, we have developed a teaching program based on 3 steps. First step, pre-cannulation education, aims at helping patients to overcome their fear of needle, teaching, for example, how the vascular access works, the importance of blood flow rate, or benefits and possible complications related to the process of self-cannulation. The second step, tandem hand cannulation, is a hands-on method where we work one-on-one with the patient with certain needles. The patient handles the needles, and the nurse places his thumb and forefinger directly behind the patient's thumb and forefinger. This not only gives the patient a feeling of security, but the nurse can feel what is happening, can verbally guide the patient, and, if necessary, can very gently guide the patient's hand. This allows the nurse the opportunity to prevent any potential complications. The training time will be different for each patient, and confidence is the key to success. When the patient feels comfortable with the process, it is time to move on. The final step, touch cannulation, is a method that differs from standard cannulation, in which the self-cannulator holds the tubing behind the needle rather than the needle wings. Holding the tubing allows the self-cannulator to feel where the needle tip is. It gives the needle tip some freedom to find its way down, preventing damage to the buttonhole tract. However, a confident, experienced patient can, if he wishes, hold himself in the needle wings. It must be emphasized too that trust and communication between the nurse and the patient has to be at a highly functional level before the process is initiated. It is the nurse's responsibility to make sure that communication is not only established, but it is also of quality in order to ensure success. So, the presented study started with the pilot phase with one patient in January of 2014. The selected patient was a 32-year-old female with almost 8 months of cannulation using buttonhole technique. After the first complete autonomous cannulation, the patient mentioned less pain during cannulation and, most of all, less fear of the needle insertion. Currently, we have another 3 patients that use the buttonhole self-cannulation. They also believe that this technique is very positive. They mentioned, for example, I prefer it, it's interesting, makes me feel more involved, more confident. This patient, for example, can't properly remove the scabs on his own, so we do that for him. Other patients said, for example, in psychological terms, it's very nice, this sense of independence. I strongly recommend this experience to other patients. Or, I participate more in my treatment. It's a different form to accept the disease. And as it is common knowledge, to accept the disease is the first stage to increase the treatment compliance. Besides the positive aspects mentioned by patients, and according to the following charts, we observe that the average values of dialysis efficiency 6 months before and 6 months after self-cannulation remained the same. Currently, after 2 years of self-cannulation, there are no significant changes too. The vascular excess flow is similar too, and the recirculation rate has significantly decreased in one of our patients. Moreover, during these 2 years of experience, no damage or any other medical complications occur in the vascular access of our patients. So, in conclusion, we believe that self-cannulation is good. We believe that patients who can use their hands well enough to self-cannulate are the best cannulators. Why? Because only patients can feel both ends of the needle. They have a better control of the needle angle and direction. They can feel when the needle tip is in the vessel, and there is a limited number of positions in which a self-cannulator can comfortably anchor his hand to achieve the correct needle angle. It's easier for a patient to duplicate this angle. So, patients are far less likely to infiltrate themselves than a dialysis nurse. A fistula with a consistent cannulator will work far longer and has fewer problems than one with multiple cannulators, since cannulation is usually accomplished by the nursing team. As it has already been mentioned, self-cannulation has several advantages. However, we consider that it must be performed under supervision. The nursing team should continue to observe closely, offering encouragement, support, and guidance as needed. Finally, I would also like to point out that we expect to have a larger number of patients self-cannulation. It is also expected that the autonomy on other aspects of the treatment will increase. However, along our experience, we realize that the hardest challenge is to overcome the fear of patients. They fear making a mistake, which may lead to an access problem. Others fear the needle itself. So we have developed some strategies to help us to contour this problem and encourage patience. Now I'm showing you highlights of a short film that we developed in collaboration with one of our patients. We use it as an educational and incentive strategy. Thank you very much.